Our next speaker, Dr. Sridevi Kalidindi. Do I pronounce your name correctly? Thank you. Well, now, Dr. Kalidindi is the National Clinical Lead for Mental Health Rehabilitation as part of NHS England's Getting It Right First Time program. I didn't know about this, so naturally I Googled it, and this is a national program designed to improve the treatment and care of patients through in-depth service review, benchmarking, and evidence-based change. Dr. Kalidindi has been awarded a CBE for services to rehabilitation psychiatry, and she is an experienced senior consultant psychiatrist, a leadership and executive coach, and also an entrepreneur. So please join me. Round of applause for Dr. Kalidindi.
Well, good morning, and thank you so much for the introduction, and thank you to Tony, GovConnect, for putting on this fantastic conference. And I know many of you are here on bursaries, so really great to start off this conversation with many of you. I just want to ask first, how many of you are rehab psychiatry or know about rehab, work in rehabilitation psychiatry? Okay, hi. And how many of you refer into rehab services or take people from rehab services? Okay, a few more. So obviously today we're going to talk about pathways, so that's really key, because actually sometimes what we think is rehab psychiatry is over here somewhere, we refer people in, and actually those individuals with complex conditions are important for the whole of our mental health system. And I'll tell you a little bit more about why. So, I'm a consultant psychiatrist at the South London and Maudsley, and I've been a consultant for, I think, going on for 17 years now. I don't know where the time has gone. And all of that in rehab psychiatry, both an inpatient ward and a community rehab team. And over the years, rehab psychiatry has very much been sidelined. And actually, I'll talk a little bit about the money that we've finally got into rehab psychiatry. The evidence base is really essential. The policy work is really crucial, and also, having really key leadership in this field. I think it's taken about pretty much all the time I've been a consultant, and there were people before me as well who've been doing this work, to make that difference and push things over the line for this cohort of people. Because often, in our current mental health system, people are very keen to think, okay, if people need to come into hospital, then let's get them out within 30 days. We know that that doesn't suit everybody, and it's about 15 to 20% of your population in secondary mental health care who fall under rehab services. So just for those of you who, just to kind of set the scene of what exactly psychiatric rehabilitation is, it really is thinking about a whole system approach, about looking at the individual, thinking about all the elements around them, both in terms of staff, in terms of environment, in terms of societal needs as well, that will help them to go on their journey of recovery. And it is really that three-pronged approach: help the individual with a full multidisciplinary team, and work to support them with all sorts of elements around improving their mental health conditions. So that is a biopsychosocial approach. Making sure that we're supporting their activities of daily living, managing their risk well, and really getting their function up and back so that they can move on to more independent settings, out of hospital and into the community, and out of 24-hour care into more independent settings wherever possible, and really getting back into their lives, work, whether that's voluntary or paid, and often reconnecting with family as well. So the bit here about modifying the environment to increase support and enable function, that's often around making sure they've got the right kind of supported housing and also the care element in the community. And that's really crucial, because otherwise what happens is they can't stay in the community and they go back into hospital. And many of the people that I've seen in my practice and also around the country, we know, can be stuck in various forms of inpatient hospitals, 10 years, 15 years. And obviously that's a great cost to themselves in terms of their lives, and it's a great cost to our mental health system and wider. And the societal change to decrease stigma around this population is really crucial as well. Because what we find is that often people will be quite concerned, say for example supported housing is an example that I have. We have people all lined up, all ready to go into their own flats, supported living, in a sort of special sheltered setting. And we couldn't get anybody in. And when we went out and talked to the individuals about the staff, they said, well, we're really worried. We haven't had anybody with this level of mental health issues before in our setting. So we went out, we did the work, we did the connecting, training people up, and also just having one person, first of all, step in to that setting and really being there for the staff so we could support them and make sure they knew that we would be on the end of that phone. And that was crucial. And then the gates were open and many more people found that after 30, 40 years in the mental health system of being in hospitals, they could have their own front door and they lived in their own flats. They could eat what they wanted. They could invite their friends and family around. It is completely transformative. And, believe it or not, it costs less to the public purse as well. So it's really a win-win. So that societal work is crucial to make these things happen. So the group we're talking about 85% have psychosis, and they really do have this longer term, usually most often treatment resistant. So that means they don't respond to antipsychotics to the point, and there's a formal sort of definition of this, but essentially many of them need to be on a drug called clozapine, plus others as well. Many of them have a lot of negative symptoms, so that whole kind of planning, the executive functioning, the socialising, it can be a challenge. And many of them have a second or third mental health diagnosis, as well as physical health diagnoses. And this varies when you look around the country. It can be from about 30% all the way up to about 70% of this cohort who will have a physical health long-term condition as well. Functional impairment, so they can't, plan and carry out their everyday living. Often behaviour that challenges, and they don't want to engage, especially if they've been in the system for a long time, because things haven't really worked for them, and they may have had quite sort of unhelpful, coercive readmissions to hospital, and not really had their needs met. And a lot of risk. Okay, I think we sometimes forget that, and often that risk is mainly towards themselves, very vulnerable to exploitation of all kinds, and in fact the risk of violence to them is far greater than the risk of violence to others, although that also does exist. So even with our fantastic early intervention services, we do have around 14%, the evidence shows, of people who still require this longer term rehab care. And this small cohort of people use a lot of resources. When I first started with my community team in Croydon, 90% of the mental health social care funding for the whole of our borough went on placements on 150 or so people. So just let that sink in. Through our team being there, doing the work, allowing people to move through, supporting them to move through to greater independence, which is lower cost as well, it's around 40%. And all of that other money then can be spent on other parts of the system for other people who require mental health care and support, and also in a much more preventative way too. So it allows the council to increase the spend right up at that preventative end as well, which we know is absolutely key. And especially given the rise in mental health conditions that we all know about, particularly through COVID and post. So we had a little bit of information about getting it right first time. How many of you have heard of getting it right first time? Yeah, I hope Guy's putting his hand up, because he's the lead for children. He's going to speak next. So, so essentially, Prof Tim Briggs, orthopaedic consultant, started this off. He noticed there's lots of variability in the way that people practice their orthopaedic surgery, really significant in terms of when somebody would carry out an operation, what kind of prosthesis they might use, what their outcomes look like in terms of infection rates, in terms of lengths of stay. He said, well, hang on, there must be a kind of a best practice here. So what he did was look at that, get all the data from around the whole country, from any system in the NHS that carried out orthopaedics. And from that, they were able to look at all the variation and try and understand where people were doing well and learn from that and spread that learning. And also understand where's a real opportunity for places to improve and then link them up, show them best practice, and really help across the whole country to raise those standards. It saved a lot of money. It got better clinical outcomes. And so the then National Medical Director said, okay, well, let's do this across all the surgical pathways and then some of the medical. And then now we've got 3 of the mental health as well, which rehab is one. So what we found in terms of the money, and you won't believe that we never have had this data until this programme. You can see the amount of money that is spent in different parts of the system. And particularly, I just wanted to draw your attention to the top line. You can see that we talk about acute adult beds all the time, day in, day out, hour by hour almost, in many of our trusts. The spend there is essentially it's $1 billion. And if you look down then to the psychiatric rehabilitation, right at the bottom to the inpatient rehab costs overall, it's over $500 million. Okay, so it's 55% of the spend on acute inpatients. We do not talk about rehab inpatients 55% of the time that we talk about are acute inpatients, not even 5%. Okay, so again, there's something about this cohort and this population that do not have a voice in our systems. Okay. So after, literally, I think the only time that this cohort had funding and resources allocated to them was when the asylums closed down, so many decades ago, and now in the long-term plan. So you can imagine that there were many conversations, many policies, much sharpening of elbows to create the condition that got rehab into the long-term plan. And you can see here that you've got in the 4th, let me see if this works, there we go, it does work. The 4th here, you can see that there is money for mental health rehabilitation and to build those community rehab teams. So we've gone now from when we started this programme to around 20 to 25% of trusts around the country having a community rehab team, now to around 80%. And the target is that every single trust needs to have a community rehab team. Because by supporting people in the community, and we'll talk about the pathways now, that is the way to really optimise the care for this group and their outcomes and the use of resources. And of course, if you think about it, everybody mostly wants to live in the community. They're not interested in living in hospital for big chunks of their life, okay? And with their sole identity in that setting being a patient. Actually, just before I just want to talk also quickly about this out of area piece. So you can see here that the rehab out of areas, a big chunk of that money is spent, over half, on out of area. So that means people being moved away from their local trusts, their clinical teams, their families, their communities. And that is because there isn't sufficient local rehab services. And what that means is, you can imagine, this is what often you've heard in the news about people being sent away, sometimes hundreds of miles away, for many years, not having the clinical reviews, and not having a pathway back into their local systems, not having a pathway back into the community. So people are literally being, sent away and not getting, they're being maintained, not getting the active rehab. And we picked up a lot of the issues around, as did CQC, around the training and the levels of expertise that the inpatient staff had. Many of those out of areas are in the private sector. Okay. So you can imagine if most of that money, which is in the private sector now, comes back into NHS, local systems, it's more efficient. And of course, people are going to get that local care, the connection. We know that it leads to lower lengths of stay as well. There's about a 65% increase in lengths of stay when people are sent out of area. Okay, so just think about that in monetary terms as well. Each of those individuals is about 150 up to about £250,000 per year for the cost of one patient in rehab. Okay. So when we think about the pathways then, actually rehab services are relevant to all of us in mental health services, because what happens, people, where do they come from? People come into rehab services from acute inpatients, from forensic units, and also we bring people back from out of area. We then also have people referring in from community teams where people's care and treatment is just not enough to hold them. They often may be cycling in and out of acute beds in order to, before they access rehab care. And then they go into different kinds of inpatient rehab, the teams that have them, the trusts that have them, the community rehab teams as well. And the supported housing is an absolutely crucial part of that. And having the right complement of supported housing, from 24-hour care to 9 to 5 to flats with floating support that meet the needs of the local population, that's really crucial. And to keep on looking at that. So having a kind of census approach where you know where everybody is in a funded placement, be it health or social care, seeing what their plan is in 6 months, a year, 2 years. Obviously, the further out you get, the harder it is to kind of predict, but working with them and their family as well about what their wants are. And by doing that, we can make sure, for example, that we stimulate the market. Where, and just as an example, in Croydon, we had about 25 youngish people. Some of them had been there from the age of 18, and now they were 30 or 40, who had been in residential care homes. Really institutionalised, actually, in the community, but still institutionalised, having their food made for them, having their laundry done for them, all of those things, and not properly integrated into their local communities. So we found that the group that we couldn't move on were the ones who also had drug and alcohol addiction, because of some of the behaviours, some of the challenges, and also the staff didn't have the right kind of training to support that cohort. So we worked with our commissioners, and we built up a spec and opened, in fact, 4 now. That was initially 2 supported accommodation settings, and we were able to move that cohort into a place where they were much better able to get the care and treatment and support that they needed and build up those skills. And many of them then moved on from there into their own flats with floating support. So, we released about £1 million as well, which we could then use in other parts of the system for other cohorts of people, rather than those individuals, spending 30, 40,000 a year on their rehab supported residential care home. Okay, so 2 minutes. Okay, so one of the things that I wanted to talk about was if we don't have enough rehab. I've talked a little bit. People get in and keep going in and out. They get readmitted. We spend a lot of money, and they also go out of area. This is also the group who die about 20, 25 years early from their long-term physical health conditions. So it's really important that we do something about understanding better how to support them. These are some of the functions of a community rehab team. I've talked about some of them, that census approach, stimulating the market, knowing where everybody is, having those regular reviews, bringing people back from out of area and developing those local systems, and also acting as an advisory function, giving advice to others for these more complex people. We had a big reduction in NHS beds, pretty much bed for bed picked up by the private sector. And you can see this is, many of you will have seen this kind of data. This is NHS benchmarking network data. And each of these columns is a mental health trust around the country. And what we do is we share these packs, we go out and do the visits with the execs, with the clinicians and so on. And we show them where the unwarranted variation is, where they're doing well, and support them to create a plan to then follow through, which we support them with as well. So you can see here, this is showing the people who are in acute hospital beds there for 90 days or longer in psychiatric wards. And you can see the spend here. So I just really wanted to pick up, we're spending money on this cohort anyway, but often in the wrong way, in the wrong place, and not getting the outcomes that they need. This trust here was spending £30 million a year on people staying 3 months or longer in their acute inpatient beds. And this cohort definitely includes people who need rehab, and they were not getting it. Spending the money anyway, poor outcomes, poor experience. And it's also, if you think about staff well-being, it's pretty demoralising coming to work and feeling you're not doing anything for that cohort, because you can't. They're in the wrong setting, wrong skill set for the staff as well. And this is showing the number of out of areas. So you can see here, there's this trust here had 150 patients out of area. Okay, massive. That's all money that could be in their local NHS systems, doing much better. The rehab expenditure, again, it's really important. Sometimes we just think about the NHS spend, but we have to think about the private sector spend and put it together, because then that gives you the total spend to think about how can we do better with this group. And this is the weighted amount. We looked at waiting times, and we look at pathways. You know, often people are waiting up to, some of them, a year on an acute inpatients to get into rehab because there's just not enough beds. And so we're spending, again, £150,000 for that person. They're not getting the right care. So this is really important. We've built in now waiting times, and that's something that with our new rehab data dashboard, all our ICBs is one of the things they'll be looking at, as well as their out of areas. We also looked at what happens when they go into acute hospitals. And you can see here, this bottom line is that non-elective medical specialties, that rehab patients, they had a 19.1% admission rate, whereas the general population had an 8.2%. So they're really kind of going in and using those acute physical health resources as well, much greater than people who don't have rehab needs. So again, it's an opportunity, especially with integrated care systems, to do better for that population upstream. And we've actually published a paper about that that shows that they have longer lengths of stay, unsurprisingly as well, okay, and worse outcomes. So Department of Health gave us some money quite a while ago now, and we carried out a thematic review with the help of the Centre for Mental Health. And the findings are really compelling, because what they show is, and this title up here that I've put, Recognising Housing as a Mental Health Intervention, if we could find a pill that did all these things that supported housing does, we would be prescribing it. Okay, we definitely would. So it's really important that we think about that social element, psychosocial element of our mental health care as well. Okay. So I won't go through all of these, we don't have time, but I will direct you to our report, the national report with the recommendations. And we've bunched them together here, so eliminating out-of-provider placements, using data to support quality improvement for mental health rehab services. That's been really challenging. We started from such a low baseline in terms of the data, and we're still not there yet, but it is a journey, and it's improving. And strengthening those partnerships, because you can see all the different elements and moving parts that need to be thought about when we really want to create those good, effective, evidence-based local systems. Okay. And the recommendations, I spoke with so many different people, and something that I was taught by a kind of mentor of mine who created one of the national mental health policies before the long-term plan was, and one of the chief medical officers as well, was to go and speak to people and say, okay, in CQC, what could you say about this? What can you hang your hat on? What will you support? What will you resource? Having those conversations with all the relevant people, and then using that and putting that in the report in order that they also stand by your report and do that work together, collaboratively. What's the hook that is important for them? Okay, that's really crucial for any of you, and that's, I think, in all sorts of elements of our day-to-day work if we're trying to advocate and influence. Okay. And part of that was getting nice guidance for this population, commissioned and through. So there's sort of all these elements and moving parts that, you know, we have to really kind of move forward on, and building that evidence base, so which we've done over many years, in order now that we can get these services resourced. Okay, so I'm going to give a shout out to Susanna Davies. Is Susanna here? There, she's right at the back. Okay, our fantastic project manager, who is really does most of the work. Okay, so thank you, Susanna. So here we go. Have a look. There's loads of good resources on there, and really happy to speak with any of you about your local rehab services or any of the issues that I've spoken about today. I do have a little 2-minute story, but I suspect we're out of time. What do you think?
Looking back,
Oh, thank you.
I've always felt different. As a child, my father was very violent, and I was bullied at school because of the way I looked. I started therapy, and for a brief while I made progress, but inside I felt miserable and self-medicated with drink and drugs. When psychosis happens, you lose touch with reality. Once I felt so powerful that I jumped out of a hotel window and broke my back. I was sectioned and put into hospital, where I stayed for 2 years. When I was well enough, I was moved into supported housing in the community. I had a rehabilitation team who helped me recover. I went back to basics, learning how to wash myself, go out and do daily chores. Now I'm fully independent. My life feels full. In truth, I will always be vulnerable to mental health problems, but I'm not defined by them. If you're suffering, then seek help. With time and support, you will recover.
So that was a patient of ours, and it took us about 4 years to get NHS Digital to create. That was one of 3 rehab films, because there's absolutely nothing on there. So again, people don't even know about the services to ask for them, and it's usually the family who asks for them. So it is this just thinking about in the round, you know, how do you support these cohorts of people? Think about their pathways, because they get better care. We get more satisfaction because we're actually making more of a difference as staff, and we get better use of our resources so that more people can benefit from mental health services and get better outcomes. Okay, thank you.